everyone. We're just going to wait a couple more minutes for everybody to log on. We do expect that, transcription started. We do expect that a lot of people aren't going to make it today. There's a lot of vacations happening right now. So we do expect that we won't have as many people as normal, but we're going to just wait a couple more minutes. Okay, hello everybody, and welcome to the 8th session of the Integrated Behavioral Health Team Training. And Martha Saucedo is going to kick it off today, and we're going to hear from Martha on talking about metrics. So I'll turn it over to you, Martha.
Thank you. I'm actually waiting for Naftali, who will be actually talking to all of you about that.
Wait another minute or two. Yeah. Let's wait another minute or two for Naftali. It looks like some more people are logging out also, so we'll just wait for a second.
He claims that this is his baby, so we're going to be talking today, so I probably don't have the rights to be talking about that.
That's okay.
There he is.
Okay, there's Naftali. So I'm going to kick it back to Naftali and Martha, and we will get moving today. Hi, Naftali.
You're mute. You're mute.
Yes, add to the tech issues. Yes, so I just had some tech issues getting my computer going, so I had to switch computers here.
So we're ready to start. Today we're going to be talking about metrics, and Jen is going to do us the favor to share what we already shared with all of you by email, but in order to start talking about it, and as usual, we'll be monitoring the chat, answering questions. Feel free to unmute yourself. It will be easier. Go for it, Neff. And Jen, if you can share the slide, that will be fantastic.
Hey, everybody, good to meet with you all once again. Martha, just let me know. I know I've had some internet issues, so if there's some lag or anything like that, just let me know. Yes, so I know I've started too many of these discussions by talking about how unsexy these topics are, but this topic is one that's one of my favorite topics because I find numbers interesting, and I find the challenge of measuring performance of a program really, really fascinating. It's a lot of what I've had to do in my career, whether it's as a director of behavioral health or in a consulting role with an organization. So we're going to get really down and dirty, down to talking about numerators and denominators today, as we talk about how you can provide yourself, your teams, and your leadership with feedback around how you're doing what you're supposed to be doing, what your program is supposed to be doing in integrated care. Now, today we're going to focus on this one document because this is really chock full of a lot of metrics, and behind those metrics, assumptions. And I want you to, yes, take a look at the document itself, but I mostly want you to be able to think along with me on this so that you can, because most people are not going to take this dashboard and just use it as is. You're certainly free to, but most people are going to adapt it to their settings. And so for that, you need to understand the why behind the metrics. You need to understand the why behind the dashboard itself, behind the presentation of the dashboard itself, so that you can then think along with that logic and adapt it to what's going to work in your setting. And you'll also have to adapt it some to the model. You'll notice here that we're calling it a PCBH dashboard. That's because this dashboard is modeled to reflect the goals of a PCBH, primary care behavioral health model program running in a primary care clinic. A COCM approach would look slightly different than this, but honestly would have a lot of the same sorts of metrics and ideas behind it. Okay, so let's just do sort of big overview things, and feel free to throw things, as Martha said, in the chat as we go. Big overview here, you'll see that there's 3 sections to the dashboard. So there's clinical, that's the top green row, operational, and financial. Those are the 3 green rows that you see there. And then you'll notice also that the dashboard is color coded, and somehow on your screen, Jen, the orange, it looks orange, but on my screen it looks red. So that's the red. So you have red, yellow, and green, or orange with my eyes as I see it on your screen, Jen. And those, if you scroll down a little bit, Jen, you'll see that there's a code to the color, which shouldn't be surprising when you think of the colors red, yellow, and green. So the green stands for items that are either improved or you feel like really don't need attention, right? So they may not be improved necessarily, but you've just determined they don't need attention because maybe they're just at standard, right? The yellow is an indicator of 2 things, and this is important because sometimes people confuse yellow with caution, and that's not really what we mean here with caution. Oh, so somebody is not seeing the dashboard. I do see the dashboard. If you don't see the dashboard, maybe check with your setup, because several of us are seeing the dashboard on there. So
just a little. I was just gonna say a little fix is if you go all the way to the top of the screen and put like the full screen view. Sometimes that helps.
Oh yeah, that can help too. So the yellow is not a caution in this dashboard. The yellow is really, this metric is pretty steady or just not really of significant concern. In other words, it's really commensurate with what we've seen quarter to quarter. And then the red, boy, that orange is throwing me off here. The red are items that you really care about. There's like, oh yeah, something's going down with this metric, or going up if up is a bad thing with the metric, or it's really below standards. And this is something we want to pay attention to. right? So hopefully that gives you a sense of the flavor, the design of the dashboard. And this is important when you're thinking about metrics in your organization. You can adapt this to almost any dashboard you think about. The main critique that I have of dashboards is that they are often very informational, but they're not very helpful, right? They're not helpful in quickly telling you where should you focus your effort, right? And I think a good dashboard should give you that. It should give you a sense of where you should focus your effort. And so that's part of the philosophy behind this dashboard. The other piece of the philosophy behind the dashboard are selecting only the items that are actionable. In other words, there may be certain items that are interesting, but if you ask yourself the question, so what? What if this number is up or down? What would I do with that? And if you can't think of what you would do with that, then it's not a useful metric. It's just purely there. And too many dashboards incorporate all sorts of metrics that are not actionable. There's nothing that you can directly do with that. It's not going to guide your program behavior. It just is, right? So you want to avoid that. All right. A couple of other sort of high-level things as you look at the document. You'll see that it's by quarter. Now, clearly, you can choose other sorts of time periods, but in my experience, most actionable information is going to be quarter-based. And some information that you may gather may even be semi-annual based. In other words, you might want to take a look at it once or twice a year to make decisions or make an assessment of what's happening. But quarters is a pretty decent way of providing comparisons. And over time, what's helpful about a dashboard like this is that you are able to then compare quarters across years, which can be really helpful because things in primary care in particular tend to be seasonal. So you have certain kinds of productivity flows, for example, happening in the first quarter of the year. And so you can begin to compare not just sequential quarters, but say compare Q1 2022 to Q1 2021, right? And that really gives you a helpful track record of what's happening with your program over time. So you have the quarters, and in this case, we're using all quarters here for our metrics. Another key component of a dashboard here is going to be your definitions. And this is, again, a really important piece that a lot of dashboards are missing. And so what happens is there's like one person in the organization that knows what is actually behind the numbers in the dashboard, and everybody else is just taking at face value that they understand what the metric is, right? But having a very clear definition that clearly outlines your numerator and your denominator is absolutely crucial to having everybody on board. They're looking at the right information and the relevant information when they look at the metric. So that's why we include the definitions there. Plus, it's just helpful for you all as you think about whether you want to incorporate these into some of your integrated care programs to make those decisions. And finally, we incorporate a notes column there, just simply because there's often things that there's things that just may change with your data and your data collection. So, something with a table in EHR, you figure out that something, you changed the strategy with how you extracted the data, and you want to make sure you put that in the notes there, or any other explanatory information you can put there as well. So those are the elements here. Now, the last piece is on the very far left, column A. You'll see the titles for each of the metrics. And we're going to go through one by one each of the metrics here as efficiently as we can to give you a feel for what these metrics are, why we selected these metrics, and how you might use these metrics, what's actionable about these metrics. So we'll jump right in. In the clinical category, we have what we're calling here a service delivery rating, right? Now, what do we mean by that? Well, typically in a dashboard, you're going to want to have some sort of indicator of what the outcomes of your service are. Now, for some folks, they use purely clinical data, right? So some of you already are likely collecting PHQ-9 data, for example. And so you can certainly look at PHQ-9 data and say, well, you can look at a metric like how many patients have we have achieved remission, for example, which is a pretty standard HEDIS related type measure. Now, you know, I didn't choose that here, but that's definitely one that you can choose to put here. I chose one that's a little bit more non-traditional, just to get you thinking, and because we often encourage programs to think a little bit more broadly around their clinical metrics and their service metrics than just a PHQ-9 score, and I'll explain that in a second. Right, but that's one potential category. You can do some clinical outcomes measurement here. The other category that clinics often use are patient satisfaction measures to see, well, are patients, you know, what are people service? And so they may have a survey and they may include a question on the survey here, you know, and say, you know, 85% of our patients said that they were significantly helped by their behavioral health visit in this quarter, right? So that's another category. And again, we didn't include that here because we included a category of clinical outcome that is still fairly unique, but has some emerging evidence behind it. We used a metric here called the outcome rating scale. And there's actually an article on it, I think it was last year. It was a randomized controlled trial using this outcome rating scale. It's a 4-measure tool. And the tool asks the patient to actually just draw a line on a continuum for each of the 4 areas that it asks. So it asks things like, you know, how are you doing in your social life? How are you doing in your work life? How are you doing in your relationships? How are you doing in general? And a patient draws a line, and you provide some, and that provides a score, essentially.
We actually shared that in our previous meeting last month.
That's right.
With all of you
That's
guys.
right. That's the tool we're referring to. And so then the definition here that we developed from that is the percent mean change in that score in sampled patients, right? So you notice that in the definition, we clarified this is not every patient potentially, because every patient may not get an OR, but in those patients who are sampled, and of course, those patients who had more than one data point in that quarter, that's the percent mean change in score. So it could be a positive or negative, right? Obviously, in terms of the ORS, you actually want the score to be higher. So a positive is a good thing, whereas that would be different if you had a PHQ-9 score where you want the score to be lower. So you'll see there in the column that in quarter 1, 22%, there was a 22% mean change in ORS scores. That's a good thing. 22% change in their scores is a pretty sizable change in scores on that instrument. And then we see this steady range of scores, 19%, 15%, 23% across all the quarters, right? And so we're not concerned in that area. It sounds like from a clinical standpoint, patients are benefiting from our behavioral health services, and our scores are pretty consistent over time. And some of this you'd have to kind of have some baseline data to assess where you were to begin with. We're just pretending we're just starting from scratch here, right? So it gives you a sense of how you would present this data, how you'd think about the numerator and denominator here for this particular metric. And then on the note side, we just put in some notes. This is actually from a particular health center who's doing this. that are specific to their data collection efforts. So whoever's doing the data collection does it consistently each and every time, and that we're comparing apples to apples across quarters, right? So that's all that is in the notes section. The specifics of it, don't pay attention to it. It's just what this health center does specifically when they're doing the analysis for that metric. But again, you can do this with PHQ-9 scores. You can do this with GAD-7 scores. You can do this with any other measure of quality of life. You can do this with the outcome rating scale. You can do this with a patient satisfaction scale. What you're looking for is, what does this help us with? What would it change if, for example, instead of a yellow, we saw a drop, a significant drop in percent mean change? And maybe if we saw a 5% rating for a quarter, what would we do with that, right? That's the important question to ask yourself. So in this case, what I would do is probably go back to my clinicians and say, hey, we're looking at this. Is there some other explanation for the data? Or are there some things that are happening, changes in the patient population? Or do we need to do some work from a clinical standpoint to provide better support, training for our staff, to provide targeted intervention to our patients, because our patients are not showing change in their outcomes, right? So that's how you would use the metric in your rating. Now, a key point here is that some of the use of metrics is internal and some of it is external, right? So that's describing an internal use. I'm going to look at this metric, go back to my behavioral health team, and give them feedback on this and say, hey, with curiosity, what do we think is happening here? What are some of the things that we think might be influencing this reduction in benefit that our patients are receiving? That's an internal way of using the metric. There's also external ways as well. So if you have a grant, for example, that you're writing for, it's great to be able to have this data handy and to be able to integrate into that grant. We do regular clinical outcomes measurement, and here is our data on this. So that's an external way of using the metric as well. All right, let's move on here to one of our other clinical metrics, and that's I'm going to go down actually to the 7th row, provider impact, because this is one that's very germane to PCBH. So with this metric, the way we're defining it is that it's the percent of providers referring more than a certain number of patients. So the XX there is stand-in for a number, right? And so you can choose whatever number makes sense for your particular organization and what baseline you want to use. Let's say, for example, we chose, more than 20 patients in the quarter, right? So the way that we would calculate that metric is simple. The denominator of that metric is all your providers, the number of all your providers. And then the numerator would be the number of all the providers who referred 20 or more patients in that given quarter. And so what are we getting at here? Well, clearly what we're getting at is, what is the breadth of providers who are engaged with behavioral health issues and referring proactively patients to the behavioral health service? That's a really important metric, because if you see a stark change, so for example, in this case, there was a red in Q1, like 30% was really low. Only 30% of providers referred more than 20 patients that quarter. Then we take some action, and in Q2 we do some emails with providers. We do some we start talking with providers proactively. We figure out that our behavioral health consultants are not visible on the pods, and that's affecting referral rates. So we make some changes, and then we see, we got a 5% increase in Q2. And then we maintain those activities, and we get it up to about 40% in Q3. That really tells us that what we're doing seems to be having an effect. More providers are referring patients to the service. It's not just one or two providers in the service providing patients, right? So that gives you a sense of how you construct these metrics, and then hopefully, then again, how these are very actionable items. Now, let's go back to rows 5 and 6 there under clinical service delivery. These are a little bit more complicated perhaps to wrap your head around, but they're important metrics when it comes to issues of equity. So the diversity impact, for example, is a metric that we use to see if only certain portions of our population are receiving behavioral health support services as part of their primary care. So I think we can all agree that if we have a certain patient population and only a certain group is receiving care, that is not equitable and not a good outcome. It's not going to help us have good outcomes across our population, right? So, you know, a quick sort of anecdote about that is that in my clinic at UNC, I've noticed that after the pandemic, Latino patients are not receiving PHQ-9s, potentially other patient groups. And I think actually PHQ-9s in general, administration in general, has dropped. But it's been affecting Latino populations because I oversee a registry of Latino patients at the clinic, and I've noticed that that registry is getting smaller and smaller. So either we are seeing less patients, less Spanish-speaking patients, or those patients are not proactively being screened for depression, right? So that's an issue, right? You want to know that as a clinic, and you want to have something that's actionable around that, right? So that's what we're getting at here with this diversity impact. And so the way we defined it here is that it's the percent of all patients seen in qualifying diversity categories, and so you have to define that, right? And you see in the notes that it's defined there for this particular exemplar clinic, and or vulnerable patient categories. So in other words, it doesn't have to be just like a racial category or an ethnic category. It can simply also be a category that is sort of an other category of vulnerability or another category of diversity in your patient population. So if you see in the notes there, right, there's 3 categories that are specific for this particular clinic, which are uninsured folks, non-English speakers, and non-white populations. So that comprises the inclusion criteria for the metric. So the denominator then is all those patients seen by behavioral health, right? And then the numerator are all those folks who fit that category, right? And we get a percent of those patients. And so we see there that we've got some red in that metric, right? So that metric is telling us, Q1 we saw 65% of our patients were in this category of diversity or vulnerability in our population. And then we see that that drops pretty significantly and kind of stays at that 50%-ish range. That would be something as a director that I'd want to look into and say, I'd go back to my team, I'd go back to our QI people, our data people, I'd look at some of the referral statistics and do a deeper dive there and see, is this an issue that the providers are just not attending to these needs when they're working with these vulnerable groups and not sending them over to us? Is there some other issue? Maybe we just have less of those patients as a clinic and they're just fewer referrals. What is going on here, right? We'd want to investigate that because we don't want inequities to just seep their way in to our clinical service.
Neff, I think you bring something that it's important when you mentioned that when you want to investigate, you open the communication between also the quality people or the physicians, because a lot of times I feel that sites will do this in an isolation, just like the BHC team or the medical team, without communicating with administratives or leadership groups, and then there's a big disconnection in the dashboard. It will be great for that clinical people think it's great, but it doesn't make sense probably for leadership or the quality people. So it's very important, as we have mentioned in other meetings, to keep that communication open between the different departments of your sites.
Great point, Martha. And just to add to that, when you then have a conversation over numbers like this, it really facilitates having a concrete conversation than sort of I don't know, a more generic or broad conversation where people can get defensive or feel like they're not really tracking you, right? Being able to present data like this is a great way to get things done across an organization, because then you look at this, you explain the metric to your admin people and say, look, this is what's happening. We're trying to investigate. What do you all think, right? It's a very different conversation than if you don't have that information at your disposal. Now, another related to that point, Martha, is this complexity ratio in row 6. Because a lot of times our metrics are just focused in on mental health conditions. But we have to remember that our goal is to really enhance all of primary care in PCBH specifically. And one of the ways that I've conceptualized that, different than, say, maybe some standard HEDIS measures, is HEDIS measures are usually disease specific, like specific to diabetes, for example. What's not helpful about that, and I think what's not helpful about HEDIS measures in general, is that they treat patients, the denominator in those metrics are patients with a specific condition. And in truth, when we're working with patients in primary care, we don't ever treat them as a patient with a condition. It's usually a series of issues and components in their life that lead up to a factor that impacts how much resource we have to put into that patient to support them. And so what we're really dealing with patients is their level of complexity. That's the real rub in primary care, because more complex patients typically need more resources. And so then we have to allocate those resources to those folks. And now, yes, it's true that folks with chronic illnesses tend to be more complex. That's definitely the case, but that's not the entirety of that. So you can design a complexity ratio however you wish. The way we designed it here, again, for this particular exemplar clinic, was to say that you were considered complex, according to this metric, if you had at least one chronic medical issue or one behavioral health condition on your problem list, right? So that means you have, maybe a diagnosis of diabetes and a diagnosis of generalized anxiety disorder or depression, right? And so what this does is help us to see, in the behavioral health service, are we being helpful collaborators with our primary care colleagues alongside these complex patients? And we obviously would want to see this number be relatively high, because if we are not seeing complex patients, we're probably not being terribly helpful to our teammates, because these are particularly the ones that we want to be helpful with. So if you look at the metric, you see that in this particular clinic, a lot of their patients are complex as a baseline, probably an FQHC, for example. So 89% of the patients seen by behavioral health in that quarter in Q1 met the criteria. Almost 90% of those patients were able to be defined as complex patients. Again, that's a helpful internal metric because you want to be able to ascertain, are we being helpful to our teammates? It's also helpful externally when you need to report out to other funding agencies, et cetera. And you can say, hey, we are assisting not just the behavioral health needs of our patients, but we are also assisting the needs of chronic medical conditions. Now, you may design the definition differently. You can add, for example, social determinant of health. You can design one that says something in your problem list that's medical, something that's behavioral, and a social determinant of health, a positive on a social determinant of health, whether it's housing insecurity, food issues, et cetera, right? That really depends on what really is going to be an adequate criteria for your particular patient population. All right, so that takes us through the clinical category. Let's move down then now to the operational category, which I think is even more fun to think about. And I'll give you some things to ponder as you think about how you evaluate implementation of a program. Right, so remember the PCBH, the gold standard for PCBH, or the true north, I should say, of PCBH is access. Right, we're trying to fix the access issue in PCBH. So we need metrics that help tell us whether we are adequately providing access care. So the first two metrics are along those lines. So the first metric should be familiar to many of you in primary care, time to third next available, right? So what is this for those of you that don't know? It means if you look at a person's schedule and you say, when is the third next available follow-up appointment that this person has on their schedule? Remember that behavioral health consultants also do have follow-up appointments on their schedule, in addition to spaces for warm handoffs. So you would just be looking at the follow-up slots. And in this case, you would be looking at the end of the quarter as a snapshot. And you'd look and see, oh, Martha, let's look at Martha's schedule. Martha's first next available appointment is in 2 weeks on Wednesday. Her second next available is on Friday. And her third next available is that Monday. So let's call it about 2.5 days, 2.5 weeks, or let's say, 18 days, let's say, right? That's the way you would design that metric, right? The idea, of course, is if Martha's patients can't establish a follow-up for too long of a period of time, Martha can no longer provide adequate care for patients. She can't see a follow-up in a reasonable amount of time. That's not good care, right? If someone's waiting 6 weeks to be seen in PCBH, that is a lifetime. That's not something that you want to have happen. So
I think also these metrics help us that sometimes you get into bad habits that you are not aware when you are working. So by keeping track of these metrics, you realize, whoa, what's happening here? What I am doing this? I think we shared with the team very early that this happened to both of us when COVID hit it, and we were feeling a little bit anxious and giving follow-ups too soon. But this type of metrics was a way to wake up a call and say, hey, what's going on? And really think about more individually as a clinician. I'm getting into a pattern here that is actually removing me for what really PCBH it should be.
Absolutely, yeah. In fact, this particular metric was the one that woke me up because I realized that my time to third next available was actually several months out. So that's not PCBH. You can't be backed up, and I can't see a patient for a follow-up appointment in 2 months. That's not PCBH. That's really making me inaccessible to the population. And it makes it very hard to even take a warm handoff, because the next time you could see that warm handoff on a follow-up would be quite a ways down the road. So you see here on the metrics here for this particular exemplar clinic that they started off with a time to next available of 13 days. In other words, the third next available was 13 days after the end of the quarter. And then, stayed pretty steady there in Q2 at 11 days. And then we saw a jump in Q3 and Q4. And that's where what Martha said is really important. That's when, as a team, you'd want to have a conversation and say, what's happening here? Why is our time to next available extending out to almost a month here on average for the team? So this is averaged across all the team members, right? And then you have a conversation. Maybe your clinical habits have changed. Maybe there's some other reason why maybe demand is up. Lots of different reasons, but you'd want to look at this and take action. And the team could then start to recalibrate how they dose and titrate care, right? You'd have to be more conscious of when you're bringing patients back, so you're not bringing them back so quickly that everybody is coming back in 2 weeks, which means you're going to be booked in 2 weeks instead of spacing patients out 2 weeks, 4 weeks, 6 weeks, etc. So the second accessibility metric below that is similar in terms of how it provides feedback to the clinician for PCBH fidelity. And that is essentially how it is that a person is dosing and titrating care as far as follow-up goes. So as I said, if I bring someone back, if I bring my patients back, like in specialty mental health, it's very common to bring a patient back on a weekly basis or even a bi-weekly basis. And so if you bring everybody back that way, That's kind of convenient in specialty therapy because of the way specialty therapy is arranged. And you're just going to follow patients in that very intensive way. In primary care, we're looking for more diversity of follow-up titration. So some of my patients might have, a portion of my patients might be coming back in 2 weeks, another portion might be coming back in 4 weeks, another portion might be coming back in 6 weeks or more. Some patients might just be seeing me that one time, right? So a good behavioral health consultant in primary care will have a range, sort of a bell curve of distribution of follow-up. If this metric, average duration between visits, is too small, that's telling you that the behavioral health consultant is bringing back patients too quickly. And that's going to lead to the average time to third next available lengthening out over time. So for example, the average duration between visits in Q1 for this team was 4 weeks. And then we see that pretty much the same, about 3.5 weeks in Q2. Lo and behold, we see Q3 down to 2 weeks. So the average time that a patient followed up was 2 weeks, and then worsened even a little bit more, 1.5 weeks there in Q4. So that's probably why the time to third next available also increased, because you kept bringing everybody back so soon that the schedule just got booked up, right? So you see how this is really helpful to give your teams information about how they are titrating care across the population. This is something that unfortunately clinics do not pay enough attention to as far as giving feedback to their clinicians. They just assume that clinicians know how to dose and titrate care and that they are taking the population needs into consideration. But the truth is clinicians see what they see, right? They can only see their own panels, that those are the blinders. They need this information to help them understand it's not just about the patients I'm seeing, it's about all the patients that we are seeing together in primary care, and we need to maintain that access. All right, another feedback piece is the length of the consult. Why? Because in PCBH, again, we also have a diversity of session lengths. Again, in specialty care, there's usually standardized. You see someone for an hour. Maybe you might see someone for an hour and a half for an intake or something like that. In primary care, we might see someone for 15 minutes or 16 minutes if we're coding 90832. We might see someone for 30 minutes. Occasionally, we might see someone for 40, 45 minutes, right? But we want to see good diversity with most of our visits in that 16 to 30-minute range. And so this metric attempts to get at that. This is a tough metric to actually put together because there's no natural way to stopwatch someone every time they're seeing a patient. But a proxy for that is the use of the CPT code for that visit. And so what you have here in the metric is the first number, the first percent, is the percent of the 90832 code, or the 96158, because those two codes are 16-minute codes, meaning there's a minimum of 16 minutes that you're spending with the patient in order to use those codes, right? So if you remember from our billing conversation, 90832 is a psychotherapy code, 16 to 30 some odd minutes. And then the 96158 is a health and behavior code, again, billed in increments of 16 plus minutes, right? And so what you're looking at is what percent of the codes were in either of those categories. And that's what that first number is. So for example, in Q1, 60% of the codes were either 90832 or 96158, right? So the majority of the codes billed in that quarter were that. So that gives you some sense that folks are within proper specs for the model, typically. You see Q2, not a big change, but you see the beginning of a trend because by Q3, you see, the consult length has gone up because only 40% of the codes were in that category. And again, 36% in Q4. That gives you a sense that the other codes, which are longer time period codes, are being used to a greater degree. So now we see 3 indicators that your team is really straying from a PCBH approach, right? We see that they're spending more time with patients. They're bringing those patients back quicker or sooner on a more regular basis. And the time to third next available, the time when a follow-up is available, has decreased as a result. Again, this provides you with some actionable element there to act on and say, okay, how can we maybe do some training on targeted interventions? How can we talk about why our clinicians are potentially taking more time with folks? Are there maybe some flow issues that are happening that are lengthening times with patients? All right, on to the next exciting metric here. And actually, this is exciting because this is really the gold standard for PCBH, population penetrance. So when you think about how your service is growing over time as a group, you're going to think about whether you are impacting more and more of the population. And so this metric hits at that. The denominator here is simple. It's the total of all the primary care patients seen, right? Because that's your population. That's who you want to impact. And then the numerator is the raw number of unique patients seen. In other words, here, remember, we're talking about unique patients, not visits, right? So the raw number of unique patients seen. And when we see seen, we need seen, meaning they had a touch with behavioral health. So at a robust primary care service, meaning some of the leading programs in the country, you're typically going to see penetration rates of about 20% or more, right? That means 1 out of every 5 patients who came to see us that quarter received a touch from behavioral health. That's population penetration. Programs that are earlier on in their development usually see rates in the 10 to 15%, or even sometimes below 10% if they are not staffed all the way, right? So again, what does this tell you? Well, if your penetration rates are increasing, that's great. That means your providers are referring, more and more patients are benefiting from the behavioral health service, and your service is truly integrated because you're not just serving a very small select portion of the patient population, you're really broadening your impact across the population. All right, so population penetration. Given time, I'm just going to skip down here to visits per patient, because that's another important metric here. So again, if you're following a PCBH approach, you're not going to be typically seeing patients for, 20 sessions in a year, right? That's specialty therapy. If someone needs that kind of intensive support, that's specialty therapy, right? So you want to be tracking what are the average number of visits that each patient receives. If you have someone spending 20 visits with someone, well, they're not going to impact the population very much because that person is taking up a bunch of that clinician's time. So this metric is really simple. It says, well, what's the average number of times that each patient sees you? And in your data, if you look at PCBH data, you're going to have a lot of folks, maybe up to 40% or so of folks who have these one-time visits, so that their number of visits is 1. You're going to have a small percentage of folks, usually between 10 and 15%, who have 6 or more visits with the behavioral health consultant. And then you're going to have most of the folks in that in-between category, where they're going to have between 2 and 5 visits. If you have a distribution like that, that looks fantastic. Usually when you do that distribution and you average that out, you're going to get to somewhere between an average of 2 to 3 visits per patient. Now, this is usually across at least the 6-month period, right? So that's an important 6-month or year period. So if you look at the metric and if you see that the average number of visits per patient is increasing, right? Let's say your average number of visits is 6. Then you know that you're probably not following typical PCBH model. Your folks are operating more in a specialty co-located type fashion, because it's to have an average of 6 means you've got some folks getting 10, 12 visits a year or more, And then that, of course, is going to impact our true north, which is our access. The warm handoff ratio, the last metric I'll talk about here in the operational category, is also a simple metric. The metric is simply the percent of same-day visits, right? So it's those visits that you have that are unplanned, essentially, that are not in those follow-up slots. Now, this can be a little tricky because not all EHRs really have the capacity to make this obvious, right? So, for example, in Epic, in most of the instances that I've seen, when we do scheduling, there's no way to determine after the fact whether a patient was scheduled that same day, meaning a warm handoff that same day, or whether they were in a follow-up slot, meaning they were scheduled, pre-scheduled from another maybe warm handoff on a different day. So oftentimes you have to find some workarounds to kind of determine what this looks like. Some people will create an office visit type and then schedule warm handoffs with that particular office visit type. Sometimes there are some things you can do with the data where you can look at the date that the appointment was made and then use that to segment out the warm handoffs. But in any case, the metric is simple. It's of all the patients that we saw in behavioral health, how many of those were same day visits? Now remember that we want to prioritize that same day work. So we want to get as close to 50-50 as possible, meaning half of the patients we see are patients that were seen same day and half were follow-up visits from patients who were seen prior, and there's some continuity work that we're going to work on with those folks. So you see here in the metrics that clearly this clinic established a baseline of about 44, 46, and they were pretty happy there. But then they saw a stark decline in warm handoffs, which again coincides with the rest of the data here. Their visit length is increasing, their time to next available is increasing, their access is decreasing as a result. And as a result, the providers are not providing any warm handoffs because they're not really available. And so that obviously would be actionable information to work with. All right, last category here, and probably the least exciting category here. But I think there's some nuggets here for you to think about when you think about financial metrics. Because a lot of people struggle with this category. And they struggle with it because, well, lack of knowledge and understanding, but often because billing departments are often a little bit obtuse about this data and what it means. And so what I generally recommend is that although it would be ideal to have actual accounts receivable data, in other words, it would be ideal to have the exact literal amount of how much billed funds were paid back to the clinic. But there are all sorts of issues typically in health entities that keep us from actually getting to that level of granularity, especially on a quarter by quarter basis. So it gets really tough to get that number from a billing department, no matter the size of your institution, small or large. Some of that, if you know anything about billing, is just how billing happens, right? I mean, you may get paid 90 days after an encounter. And so there's delay there. And then there's just difficulty wrangling some of that data as well, especially if you have some fee-for-service contracts and some value-based contracts, it can be pretty jumbled. So what I recommend as a proxy for financial performance is to really look at charges generated. So charges generated is just what your entity billed out, right? And this is usually an easier number to get from your billing people because it's just based on the work you did and what you sent out. It's not based on anything that came back, right? So it's not exact because usually whatever you charged out is not exactly what you're going to get back. You're usually going to get something less back, sometimes substantially less back, amazingly enough, right? But it's still a proxy for the billing potential of the team. And so charges is just an easier metric for your billing people to produce and for you to track over time as a proxy. Again, a proxy for how your finances are going. The other key piece here, if you look at the second category of other funds that people often don't include in their dashboards, is really other things that are feeding into the behavioral health program. Could be a grant, for example, could be a value-based payment that your organization is getting related to behavioral health metrics. Those should be part of what the behavioral health team is credited for financially. A lot of times I see organizations, they just sink it into general funds and don't even credit it and just expect behavioral health to fund itself just based off fee for service. But you really should be adding in all of those funds that have been attracted to the organization because you have behavioral health. So an example of that is at the clinic in Madison where I used to work at, that we had a lot of funds come into the clinic, not even specific to behavioral health, but because we were a medical home that had a well-respected integrated care program, the clinic was able to apply for grant funding and other sources of funds from the community because of the reputation that they had garnered because of the behavioral health integration service. And so again, that should be really credited in that category of other funds. And then, of course, to keep things simple, you want to have some metric that says, well, but how much have we incurred in terms of costs, right? So the main cost of any behavioral health service is going to be salary. And then your CFO can often apportion a % of incidental costs or administrative overhead that they may assign to different departments. And that would be included here as well. And of course, that's just a metric to say, all right, how much are we costing the organization? And then we can compare that to how much revenue generating potential we have. That gives us a clearer idea of a net, right? Now, again, is this exact? No, it is not exact. You may want to have other data reported to you from accounting that's more specific to the payers and how much they're paying out, and maybe some more granular data around what you're actually receiving as far as payment for work done. But a dashboard, remember, is not supposed to be perfect. It's supposed to be something you look at just like you look at your car dashboard that gives you an idea of what's happening, and idea enough that you can take action on, that you would potentially make some changes on, right? So for example, that's why you have on your car that service engine check light, right? Now that service engine check light could mean about 1,500 different things, right? But it's useful as a dashboard item because it makes you take action. It makes you take the car to the mechanic to get it checked up, right? That's the function of a good dashboard. So this is an exemplar. It's not perfect, but hopefully it gives you an idea of the categories, of some of the metric examples, of how you design these metrics, and then how you take action on these metrics in a behavioral health integration program for you to monitor your program effectively over time. Okay, I've talked for a very long time. Do we have an example of a dashboard for COCM? No, but we can certainly get you one. Absolutely. That would have taken another hour. So if you have any questions or comments after the fact about this, any questions about these metrics, we're happy to answer them offline. We know that we're at the end here. If you have anything burning now in the last 3 minutes of our time, definitely post it on the chat.
I want to say something really quickly, Natalia, and that is Abby Harburn is on the call, and she is our a manager of data analytics at WCHQ, and I asked her to join because WCHQ has a lot of the data from our health systems that we can slice and dice in different ways. So I want you guys to think about what you heard today and come to us with ideas about what we can do for you. We wrote into this grant some data analytics. So we want to help you guys pull out information that would be helpful to you. So I want you guys to think about today what would be helpful to you, and please send me an email offline and let me know what we can do to support you guys through our analytics department.
That's great. And also, it reminds me that for those of you who have established co-located behavioral health services, meaning specialty behavioral health, you can use some of these metrics as well. They are specific to PCBH, but they can help you think through your access issues with specialty mental health as well.
I think Abby just chimed in the chat some other ideas. She's looking forward to working with you guys. So if there's anything else that comes up, thank you guys very much. I know it's the top of the hour. Be looking out for the follow-up survey for me, as well as the video. We sure appreciate you guys attending these sessions and giving us feedback. And Neftali and Martha, thank you again for an excellent session. Appreciate everybody's time.
Thank you, everyone.
See you day, everybody.